Welcome, everyone. We are so glad to have you here for our webinar this afternoon or morning, depending on where you're joining us from. Our webinar is called More Than Checking a Box, Strengthening Diversity, Equity, and Inclusion in Children's Hospital Patient and Family Advisory Councils. I just want to note that throughout this webinar, you may hear me and other presenters and panelists talk about DEI, using an abbreviation for Diversity, Equity, and Inclusion, and PFACS for Patient and Family Advisory Councils. And I imagine that sometimes we'll slip in PFAs, Patient and Family Advisors, as well. Just wanted to make sure that we were clear up front about that. I am Pam Dardis, Vice President at the Institute for Patient and Family-Centered Care, and I'm joined today by my colleagues Deborah Dawkin and Ushma Patel, along with Dr. Ndidi Unaka from Cincinnati Children's Hospital Medical Center. We also have a wonderful panel of individuals who we will introduce to you later in the webinar. Next slide, please. Just some housekeeping tips before we get started. So all of you are currently muted. We encourage you to use the chat box for comments and questions. Please feel free throughout the presentation today, throughout the discussion. If you have any questions, if you have pearls of wisdom that you would like to share with others or information about your experiences, we do want this to be a lively chat, so please feel free to include those questions and comments in the chat box. Ushma is going to put some links in the chat. We do have some handouts available in association with the webinar today, so she will put those in the chat and you will be able to access them. If you have any technical issues at any point during the webinar today, you can direct chat with Matt DeSilva on our team. It says IPFCC Matt DeSilva. He should be able to help you with any technical issues. And then finally, after the webinar, we will make a recording available on IPFCC's website. Everybody who registered for the webinar will get an email about that, and that will be available to everyone. Next slide, please. During our time together, we're going to talk a little bit about a project that we have been conducting over the past 16 months or so, and share with you some of the findings from that project that focuses on advancing diversity, equity, and inclusion in relation to Children's Hospital PFACS. You're also going to hear from my colleague Deborah about a new resource that we have developed that includes opportunities for action as we think about how to push this work further. And then I'm so excited that we have a panel of experts who you will be able to hear from today, who are on the ground doing this work day in and day out, and are here to share their experiences, their wisdom, their questions with us. So we will have Q&A. Please feel free, if you are like me and you will not remember your question by the time we get to question and answer, please put it in the chat. We will keep track of those and make sure that we get them to everyone. Next slide, please. I want to acknowledge support for this work and this project from the Lucille Packard Foundation for Children's Health, and also to just extend deep thanks to our project officers who have both been incredibly supportive of this work as we've gone forward. Next slide, please. This is the team of individuals who have been working hard on this project over the past year and a half or so. We are very fortunate that this is a joint effort between the Institute for Patient and Family-Centered Care and Cincinnati Children's Hospital Medical Center. We have been able to partner with them on this and other work, and we're very grateful for that. Next slide, please. We have a whole host of other people who have offered their experiences, perspectives, and wisdom to this project. These are members of our National Project Advisory Council. You'll see that we were able to gather together a group of people who are working within children's hospitals, people who are family leaders, individuals who have expertise related to community engagement and patient and family engagement and partnership, people who bring broader policy perspectives, and all of them have been instrumental in contributing to this work. Next slide, please. So let me share with you a little bit of background about this project before Deborah shares some of our key learnings. Next slide, please. So this work grew out of another project that we conducted in 2020-2021, again with support from the Lucille Packard Foundation for Children's Health. During that time, we conducted a nationwide survey of children's hospitals. We were able to survey 228 children's hospitals, so we actually got survey responses from that number, which was a 73% response rate. The purpose of this survey was to learn a little bit more about the prevalence and also the functioning of advisory councils within children's hospitals. So we wanted to learn, do children's hospitals have PFACS? How are they working with their patient and family advisors? What we learned in this project is that there is a very strong foundation of advisory councils within children's hospitals. 88% of our respondents reported having at least one PFAC. Another 8% had a PFAC in development at the time of the survey. You can also see from the pie chart that many hospitals had multiple PFACs, and in addition, there were a number of hospitals, over half, who had advisory councils that had been in existence for at least 10 years. So there's a deep, deep history in children's hospitals of this type of partnership. Next slide, please. Along with some of the strengths that we found, we also identified some challenges. And one of those challenges that came through loud and clear was diversity of patient and family advisors. 62% of respondents to the survey identified difficulty recruiting or retaining advisors who reflected the broader diversity of the patient and family population as one of their 3 most significant challenges when it came to their advisory council. So as you can see the quote there, we also heard in interviews that people were struggling to ensure that membership of the council reflected the hospital's patient and family population. We had one interview participant share with us that they had done a survey across their health system and identified that upwards of 80% of their advisors were white. Almost 2/3 had a master's degree or higher, and nearly 75% had a household income of at least $150,000. So that represented their demographic, and obviously that was not the demographic of their entire patient and family population that they were serving. Next slide, please. Another aspect of diversity that we looked at was the extent to which patient and family advisors are involved and integrated and partnered in work related to DEI. When we asked this on the survey, only 27% of respondents indicated that they had integrated advisors into committees working on diversity, equity, and inclusion, despite the fact that DEI in general was receiving more attention within the hospitals. Patient and family advisors were not necessarily being involved in that work. So taken together, these challenges place healthcare organizations at risk of not obtaining input and perspectives from the diversity of patients and families served, particularly thinking about populations that are historically marginalized and underrepresented. So because having a PFAC that is reflective of the patient and family population served means that an organization can be better positioned to help address health inequities, improve safety and experiences of care and quality, and address issues related to social justice, we really wanted to dig a little bit more into the issue of diversity, equity, and inclusion as it relates to PFACS. Next slide, please. So with that, these were the goals and questions that really guided our work on this project. We had 2 primary goals. So the first goal was really about identifying and sharing learnings related to increasing the diversity of patient and family advisors, particularly thinking about developing and supporting and sustaining partnerships with advisors from historically marginalized populations. Another goal was also to identify and share examples of and learnings about partnerships with patient and family advisors and advisory councils in DEI work. So looking for where organizations have done that and how they have done that successfully. Next slide, please. So we accomplished this through several activities. We conducted a targeted review of the literature. So this was not an all expansive, comprehensive review, but we did seek out and review articles and documents, and particularly resources that were designed to support implementation when it came to either increasing diversity of advisory councils or thinking about how to partner with patients and families in work related to DEI. We also conducted 18 key informant interviews with individuals from children's hospitals, but also expanded that to other child-focused health and social service organizations, in recognition that there's a lot of good work going on outside of children's hospitals with potentially some lessons learned that we can bring in to the children's hospital world. And then really importantly, we conducted 4 focus groups with patient and family advisors who self-identified as being from historically marginalized populations and backgrounds. We wanted to learn directly from advisors what their experiences have been, what they see as key challenges, and also what they see as opportunities for improvement moving forward. Next slide, please. I'm not going to go into all of our learnings. Deborah will cover a lot of those as she reviews the resource that we developed, but there are a couple of things that I want to point out at a higher level. Across the literature, across the interviews and focus groups, what we heard in a resounding way is that this work requires intentionality. This is something that needs to be approached with a clear plan, a clear idea of goals, but also partnership with community members, with patients, with families, that this is not top-down work, that this is something that is built together. And I am sure it is no surprise to all of those of you on the webinar today who have a lot of experience working with patient and family advisory councils, inpatient and family-centered care, patient and family engagement, diversity, equity, and inclusion. This progress is not a straight line. You may take one step forward, 2 steps back. You may take 5 steps sideways. Advancements are built over time. The path may not look like what you think it's going to look like, but the point is to keep moving forward with that intentionality and partnership. What we also heard is that it's really important to think outside of the box. So if we keep doing the same things the same way that we always have done them, it's going to yield the same results. So if we are looking for different results, if we are looking to improve our partnerships with individuals from historically marginalized backgrounds, if we are looking to improve our partnership with patient and family advisors in DEI work, we need to think about other ways of doing that, being a little bit creative, learning from the community what works best for them. Then also, along with that, looking to other fields for ideas. So we learned a lot. A lot of the lessons learned that we are drawing come from fields related to community engagement, community-based participatory research, and also education, where they're struggling with many of the same issues in terms of creating partnerships in an equitable way to address some really challenging issues. So I encourage all of you, as you are listening to the rest of the webinar, to begin thinking about opportunities for how you might be able to apply some of these learnings within your own organization, questions you have about doing so, and we will try to get you as much information as we possibly can during our short time together. Next slide, please. I'm now going to turn it over to Deborah Dokken, who is going to share a little bit about the new resource that we developed. Deborah?
Thanks so much, Pam. It's always exciting to announce and share a new IPFCC resource. And this one, the title of which you see on this slide, of course, comes out of the project that Pam just described. Next slide, please. The new resource builds on an earlier one that came from the 2021 study that Pam reviewed briefly in her previous remarks. And that resource provided practical guidance and recommendations for the field about effective PFACS. That particular resource was intended for a broad audience, from new PFACS to more experienced ones. And our intent was that it would be used by leaders, staff, and of course, patient and family advisors. And as Pam mentioned, that earlier study and the resource identified some of the challenges related to DEI and PFACS. Next slide. So on this slide, you see the cover of our new resource titled Strengthening the Diversity and Role of Patient and Family Advisory Councils. The resource focuses specifically on PFACS and DEI and shares findings from the study, the recent study that Pam just reviewed. Pam shared some of the broad learnings from that study, but the resource really focuses specifically on actionable, practical findings and strategies for the field related to DEI. You see the intended audience here. Not surprisingly, PFAC coordinators, hospital DEI leads, and staff who work in DEI and PFCC, and of course, patient and family advisors. Next slide, please. The centerpiece of this resource is a one-pager near the beginning of the resource. We're going to see it now in 3 slides, but in the resource itself, it's actually one page that outlines 6 opportunities or areas for action. And the intent of having this one pager was that it could be a summary standalone that staff leading this DEI work could share with others, for example, as a handout during or after a presentation. And to some degree, the 6 opportunities or areas for action are sequential in a planning context. So let's go through them really quickly. I won't do it in detail because I know that you have the slides, and also hopefully you will all review the resource later. So the first area or opportunity starts at the beginning with defining goals for DEI. And the second area focuses on recruiting to increase diversity among PFAs and PFAC members. As an example, how to identify barriers and address them to enable participation. Next slide. The third area focuses on structures that we found facilitate PFA participation. As an example, that what some people call a tiered approach, where at one end of a spectrum, PFAs can be involved virtually, and the onboarding process is less detailed and strenuous, all the way up to PFAs who might actually be doing work within the hospital itself. Another example of one of those structures are specialty PFACS, like Spanish-speaking PFACS. The fourth area or opportunity focuses on how to support inclusive practices and environments to enable participation from more diverse PFAs. And again, this is everything from identifying and addressing specific barriers to providing training for both staff and PFAs. Next slide. The fifth opportunity or area refers to the second goal that Pam talked about with all of us, and that is, how do PFACS really partner in hospital or system-wide DEI initiatives? Because it's not enough just to increase the diversity of PFACS, but there is a need to integrate PFACS and PFAs into DEI work at the broader level. And finally, and not surprisingly, the sixth opportunity or area for action looks at ways to sustain progress that's made by PFACS in this work, how to keep the momentum going, and as an example, ways that PFACS might conduct assessments on a formal or informal basis. Next slide, please. So that was a very quick walk through this one pager that we really regard as the roadmap at the beginning of this resource. And then following this one-page roadmap, each of the 6 opportunities or areas for action has its own set of pages where more concrete, practical strategies are outlined, as well as some real-world examples from the field. Our intent in both the content and the design of the resource was that you decide which opportunity or area is most important for your organization to begin with or to focus on. For example, some organizations will begin with defining goals, while others will really want to focus on recruitment and focus in on that section of the resource. Next slide, please. So that was a very kind of whirlwind tour through the new resource, but it is already available on IPFCC's website under PFCC Best Practices, DEI, and PFACS. We hope that you will use it yourselves, that you will tell colleagues and others about its availability, and that you'll even share on social media with your networks about the resource and its availability to everyone at no cost. Next slide, please. And now it's a great pleasure to transition to the highlight of this webinar, namely a discussion with our expert and experienced panelists from the field. And Didi Unaka will facilitate and introduce the other panelists. Dr. Unaka is a key member of our partner team from Cincinnati Children's Hospital Medical Center, with whom we've worked together on this project and the previous one. So, Ndidi, take it away.
Thank you so much, Deborah. It is really amazing to be here. Thank you all for taking time out of your busy schedules to join our webinar today. I'm Ndidi Unaka. I am a pediatrician at Cincinnati Children's Hospital Medical Center and have had the pleasure of working with Pam, Deborah, Ushma, and others on this work for the past couple of years. I want to take the opportunity to have each of our panelists introduce themselves, and I will start with Kanisha to have you start us off.
Thank you so much. Hi, everyone. I'm Kanisha Dolsing. I was the former chair, and I'm the current lead of Diversity, Equity, and Inclusion at the Kamansky Children's Hospital Family Advisory Council. Thank you so much for having us. It's been amazing, and we look forward to joining in a great collaboration today. Darcel?
Thank you, Kanisha. Good afternoon, everyone. My name is Darcel Jackson. I am the manager of patient and family-centered care at Children's National in Washington, D.C. I myself have served as a PFA on our system-wide PFAC for 10 years, and I am proud to be able to co-chair some of our DEI work, sitting on our steering committee and also co-chairing our patient, family, and community engagement DEI work.
Hi, everyone. My name is Vicky Mascareño Nelson. I'm the Patient Family Centered Care Coordinator at the University of Vermont Children's Hospital and the University of Vermont Medical Center. I've been in this role since last fall, so I'm not going to call myself an expert. I'm going to call myself a champion. But I do want to say that I was an advisor on the Children's Hospital for 5 years, and I was on the council for 5 years prior to taking this role. I am on some of the committees across our hospital and our network that does DEI work. And I did want to say that for 20 years, I was a school counselor in public schools. So I'm bringing that equity lens to this work, and a shout out to any educators out there who have also made the leap to healthcare.
Thank you all for taking the time to introduce yourselves. So excited to have you all here and to share your experiences at your institutions with our attendees today. Just to orient our attendees to what this panel discussion will entail, I have a set of questions that I'm going to ask our panelists, but I encourage you to ask questions in the chat, and we should have some time to get to some of those questions before we adjourn for the day. So the first question that I want to pose to our group is, how has your work with PFACS at your organization shaped the way in which the organization has thought about DEI efforts?
I like how we're being so polite.
I know, don't be shy. Anyone can start.
I know they have great. I can jump in and then I'll hang back on the next one for sure. I would say that some of the ways it's shaped the way we're thinking about DEI is it's increased collaboration. So between our patient experience department, our DEI departments, our community health team, and I like to use the words cross-pollinate. I feel like we're doing a better job cross-pollinating and getting out of the silos that have existed for a while. I'd also say that we're shifting our culture from being transactional with our advisors into more transformational work. We're empowering advisors, we're co-designing, we're working together, getting out of that check the box kind of ideals that creates that culture around transactional spaces. I also think that we've been working harder to ensure that our advisors represent all the communities we serve. And on that note, I just want to share my orchard metaphor that I share a lot in my education, which is when I first came on a few months ago, I know that everybody, the system wanted more diversity in the advisor group. I felt it and I saw it. And I was even getting really specific, really around identities. So I get specific asks around specific identities for specific projects. And I started to think about it as an orchard. So our advisor pool or our advisor team is like an orchard, and we have different varieties of apples. And I noticed that everybody was saying, Vicki, do we have this kind of variety, this kind of variety, this kind of variety? I was like, well, we have this variety. And they're like, but do you have this, this, this? And I was like, that would be so nice to have all the varieties of apples. It'd be so nice. And I was like, and then I would say to them, can you help me plant the seeds so that we can create the orchard? And can you help cultivate the soil so that we can grow all the varieties? And I think the shift that I learned is I really have to press the system to say, you have to cultivate the soil and help plant the seeds. You can't just come extract for different identities for different needs. So trying to move that forward.
I loved so much of what you said, and I can see some of the comments in the chat. I think your analogy really resonates with people.
You know, following on from what Vicki said, collaboration is so key. I think seeing the impact has driven the momentum over the years. So the importance of getting people together, the importance of that collaboration and creating that psychologically safe space where voices are heard, and then seeing the tangible outcomes that come from that has created an excitement and a momentum that's fed through the organization. And we have really leveraged that to the max to really get that impact, both in partnership, which we talked about is so key, that we're not working in silos, that we're partnering not only on the council level, but how we are as a hospital across departments. And then even in, like, for example, in this case, how we're sharing that knowledge across nationally and making that drive. So I think what we've seen is something that's been started off as very organic, and understanding the importance of it has become very intentional. And that intentionality has helped us really put the focus on how can we ensure representation, you know, diversity, cognitive diversity, and what that impact looks like. How are we affording access and opportunity? And really, to Vicki's point, you know, laying the seeds, but also focusing on what we're doing and where those gaps are. And how are we making sure that we cultivate and foster a sense of inclusion so that we can continue driving forward?
I love that. I'll share is I agree with everything both Kenesha and Vicki said, and I will probably also give you credit, Vicki, because I'm going to have to use your orchid analogy. I think it's perfect. I think what I'll share that is because I do agree with everything that was shared. And I think our organization is doing the same thing, really how to break down these silos to partner on DEI efforts. And where I think we've had a lot of our PFACS have had a lot of influence is really for Children's National. Our PFACS were having the conversations about DEI, specifically where they saw bias and racism and inequities, even before we had our official DEI committees. And so I feel those conversations really led to bringing things up to a higher level, where I felt our patients and families were actually really leading and charging some of the work. And where that has positioned the council is really making sure then our advisors have a seat at the table in these discussions, so that they are part of our steering committee. They are part of our DEI committees and initiatives and projects, not just us asking for their participation. We want that, but also leading the charge. And when they see things and really also, so this is bilateral kind of choosing of where there's opportunities for improvement, and really establishing themselves as also leaders in the DEI work.
Thank you all so much. You know, I think so much of what you all shared, those themes really come through, right? The intentionality that is necessary to do this well, really trying to shift power dynamics such that our patients and families with lived experiences are not just at the table, but actually leading the work. Thinking about ways where we move from being more transactional to transformative and relational in our interactions. I think all of those things really are important, and I really appreciate you all sharing those very concrete examples. I would love to hear what you all are most proud of. Like, what has been your biggest win at your organization related to this work and the ways in which your PFACS have really come together? And if I can call on Kenesha to start.
Sure. So, I talked earlier about our journey starting organically, embedding diversity, equity, and inclusion in an organic way, and becoming more intentional. And I want to talk a little bit about that journey because I think it's been one of our proudest moments. So over a decade ago, we embedded cultural competency into the curriculum that we developed for training Cornell medical students. And what we found is that through fast feedback loops and learning through doing, we were having measurable and significant impact. So much so that the professor who we partnered with at the hospital was offered a Fulbright Award and was able to take all of the great work that we had done to internationally to teach, which is such a proud moment for the hospital. We're really seeing that there's no greater reward, right? We're getting that recognition. And then I talked about the fact that we've seen since the events of George Floyd a significant focus on how we're being intentional about diversity, equity, and inclusion. And so at the hospital, we took that cue and we became very focused on saying we're going to have a committee that is really called diversity, equity, and inclusion. And that it's not mutually exclusive. In fact, it's integral to it, that everything we do is through a DEI lens. And we proved out this model organically, and now we wanted to show intentionality. And what I'm so proud of is the fact that we have taken a very data-driven approach. We have gotten the right people around the table. We've created a safe space to pull this information together. And then we've identified that health equity is a significant area that we need to focus on. And so we set ourselves up to be successful, at the same time not being afraid to fail. And where we are right now, and this is such a proud moment for us, is that we're really focusing on addressing health inequities, which I'm sure you can all agree has widened significantly with the pandemic and with COVID. And we are having immense success. And what we're doing specifically is we are objectively identifying our families and patients in most immediate need and offering access to food, clothing, transportation. And we're looking at that through the lens of the social determinants of health. And very recently, we have been asked to partner with a fellow on taking the research of social determinants of health and the wonderful project that we're doing that's having that impact and take it to the next level. So we're very proud of that. And I think the final thing I'll say on this is imitation is the highest form of flattery. And we were the first FAC for our hospital with a rich history of showing how we've developed, we continuously improve, we continuously look at ways that we can be better. And now we have been the blueprint for many other PFACs across the hospital, which we're very proud to be part of.
That's really amazing, Kanisha. And, if I can pull out a couple of things that you highlighted, the importance of training and education, that has to be, it part of the strategy. Maybe it's not, what you focus on for long-term reliability, but it's critical. And then the importance of data to help inform your strategy, your goals, and obviously ensuring that you have metrics that you can work towards. And it sounds like you all have really focused on health equity as a place where you all can really try and close equity gaps. Thank you for sharing. Darcel, can I call on you to share?
Absolutely. So there's so many things that I can say that I'm proud of. One, that we're doing the work, right? That we're having the conversations with our patients and families at the table. Two specific things that come to mind. One is about representation in our marketing. I recall a lot of PFAC meetings where we did have some advisors feeling that they did not see themselves in the imagery that was around the organization or branding and marketing materials. And so our marketing team, we brought it to their attention, they heard it, and it really changed their perspective on how they do that. And so really in partnering with us, anytime they're doing marketing campaigns, to really diversify those that we reach out to try to make sure that we are representing the patients and families fully that we serve, in everything from race and ethnic background to ages of kids to disability, different abilities, from religion, diversity, and it even trickled down to just even the iconography that we use. Thinking about when you just look for icons and you kind of just do generic clip art, that is really not representative of the diverse population we serve. And so really partnering with a partner to create new iconography that really reflects the rich diversity of our patients and families. So I think that was huge. And so much so that our marketing team members now have a representative from marketing sit in each and every one of our system-wide PFAC meetings to make sure that they are always on top and kind of listening and including that in what they bring for their teams. I think the second example that I think I want to share is we had raised to our attention some from our families, specifically our Black and Brown patients, of feeling over-policed, that there were instances where behavior that they had, although it may be behaviors that others have also done, when they did it, it was really causing an increase of calls to security. And so we raised that to leadership, and they took action on it. And so what it was is really taking a look at working with our ombudsman department and our social work team to really see what is the breakdown between families who have had visitation restrictions or security called or any kind of intervention really among racial demographics to see, one, if there was a disparity, and there was, but then more importantly, what are we going to do to change it? And really developing a care model where security was not going to be the first call, first of all, and then how do we utilize our social work team to really utilize their skills and their arsenal of talent and resources to de-escalate situations. But a step further is then really follow up with the person who called the security on why did you do that? Like what was the reason that made you feel you needed to have that level of intervention, to really try to identify where there was opportunities for coaching with regards to implicit bias. And so I feel that's a proud moment of really listening to what our families are saying, owning that this could be an issue, doing the work to find not only if it was an issue, but also then what are going to solutions for it.
Darcel, thank you so much for sharing. A couple of things, there's a saying that says you can't be what you can't see, right? And I think the importance of fostering inclusivity and belonging by thinking about marketing and, the material that we're putting out and making sure everyone feels like they should and can be a part of PFACS is so important. And I just love that call out. I also really appreciate you talking about the over policing of Black and Brown families, and not only that you all are being action oriented to try and decrease those incidents, but also the feedback that you're giving to individuals who initially make the request for security. Such a teachable moment, and it's a way to really call people in. So I really appreciate you sharing that example. I would love to hear what are the challenges your organizations are facing, and what are some solutions or strategies that you all are using to address these challenges related to DEI and PFAC involvement. And Vicki, can I have you start?
Sure. And thinking about the challenges, I think we all know that's a complicated question, and I think it could be, and I wanted to not be too specific to my own organization. And I also, I'm drawing on 20 years in public education, so there's a lot of connections here. So I did think of three, more general one. And the first one I want to talk about is pacing for privilege. So the idea that the system is paced at the rate that of the most privileged, most dominant identities. That is that's structurally inherent within all of our systems, and it's true within healthcare. When I jumped over to that ship, I found that as well. And I just want to say that when I sit in spaces where I know that's what's happening, is the solution is it's to name it. It's not to shame anyone, but this work, you have to be an interrupter. You have to be able to see that we're pacing for privilege and name it, so that the group goes, there's like we can call them an equity pause. So we're pausing, we're thinking about it, and we can shift from doing things the way we've always done them to get the same results, as Pam mentioned earlier. Another one would be obviously being complicit with the systems the way they currently are. So this is a really, really small example, but when we think about diversification, I know there's a lot of different identities, and we have a lot of different work to do within our system to have our advisors represent all of the communities we serve. But here's one that was missing on our council, and that is dads. We had mostly had moms. When I first came on board a couple months ago, there's no dads. And the truth is like, I didn't want to be complicit and be like, we can't just have moms here. I mean, we have growth to do, but I worked with community partners, and I'm happy to report that last week we had 4 dads at our council meeting, and it shifted the dynamic. To be honest, it completely shifted the dynamic. And then the last challenge is, we all know this, it's funding and compensation. Again, need to name it, need to ask for it, need to be a champion for it. And also, here's what I've also learned is that the pipelines of money are often still going within into the ways that they've always been, which centers the same identities. So if we just think about where that money is going, so it's not always about more money, it's about, let's look at this pipeline of cash flow and think about, well, who else could benefit from that?
And Vicki, I just wanted to chime in to say about your dads, which really resonated with us. It's something we've actively sought out. And I'm so pleased to say that our current chair is a dad, and he's doing a phenomenal job.
That is so incredible. And it's reminded me of some work that Dr. Ray Bignell did. He's one of our members of our advisory committee. And as a resident, he did some work on really trying to understand, dad's involvement in the medical home. I think we often forget about fathers. And so I really appreciate this, that you both are bringing this up. Darcel, anything to share on your end?
Yeah, I think some of the challenges we face are probably no different than everyone else's. Is one, any conversation around diversity, equity, and inclusion is difficult. It really is. And I think so we have been challenged with that same level of difficulty. And so I think one is preparing people for the conversation, really understanding that it's not going to be easy. You may be uncomfortable, but we need it to be a place that's rooted in it being a safe space for everyone to be able to speak, to share their journeys, their experiences, whether or not that may match your experience. And so one of the things that I think we've done to help with that is one is created guiding principles. Our system-wide PFAC, as we were having these conversations, recognized we needed guiding principles to kind of ground the conversation even before we started. Really, that the purpose of this is that we're going to treat everyone with respect, but we're going to assume best intentions, that we're going to stay on topic and try to recommend and suggest solutions. It's easy to get kind of caught up and kind of share all the things that are not going right, but not really working towards how do we find those solutions, and that we're going to be constructive to make space for everyone to be able to share. And then, and Nadita, you used this term earlier, and this is of calling in. And so that final is calling in versus calling out, and really understanding it's really on the nature of the tone and how you address it, and to make it an inclusive environment. And so I think those grounding principles, which were really important, is because we started it with our system-wide PFAC, but then as other PFACs were wanting to have these conversations, we shared it. They have also started to use it, which has really allowed it to become a more really a partnership rooted in everyone being able to feel that it's a safe space to speak. But being a safe space is also an opportunity, and often hard. And so these conversations can be difficult. They can trigger a lot of feelings and emotions and disagreements. And so one of the things that we've done is partner with social work, again, which is it's a great resource for us to really have a social work kind of be stand on call to help us with these conversations. But more specifically, if it does happen to really trigger something from any of the participants, that they are able then to be guided to some of the resources that may need. And then I think the other opportunity here, often when we talk about DEI work, we're looking at the groups of people that are most incredibly impacted by the disparities and inequities to help to come with the solutions. And I think a lot of what we're hearing is we want to be here to share our experiences and to also help guide this solution, but it is not our job to find a solution to a system that we did not create. And so really not putting the onus on those populations to find all the answers. And so I think this is something that we will always continually try to learn.
Thank you so much. So much of what you, Vicki, and Kenesha shared, just, I mean, so many good things there, like our responsibility to be interrupters and disruptors, you know, our responsibility not to be complicit to the systems that currently exist, and really trying to identify ways in which we can disrupt or dismantle the systems to ensure that everyone is included. And I love the call out regarding the disproportionate burden that falls on those who are historically marginalized and oppressed to address and come up with solutions to these problems that they didn't create. And so I just really love everything that you all are sharing. And I think would love to hear from you all. What are the opportunities in your organization to improve? And in other words, what's next for your organization? You all have shared some wonderful things that you all are doing, but what's next? What's the next step? What's the next goal that you all are working towards? And Vicki, can I start with you?
Sure. I have to say, so a couple months in, we're creating another patient family advisory council. So since I work across settings, the Children's Hospital and the Medical Center, we're creating a community council. Right now it's called the Wisdom Council, but that will morph because advisors will certainly be a part of creating that. So we are in the steps of intentionality and collaboration. It is a huge team. You know, there's a pediatrician who works with migrant refugee families. We have a community center. It will be held at the community center. There's a social worker. We have community health from our health network as a part of it, translation services, someone from our DEI team. It is a real, to me, like, and I told them there's no blueprint in Vermont for this. And I think we're all trying to work on the blueprint across everywhere to do this work right. We just slowed ourselves down yesterday. I think we thought our first meeting might be in November. That is not happening. So the intentionality word is really significant. I did want to say that in terms of building this PFAC and centering everything we're talking about today is intentionality and collaboration, and it's messy. So I just want to be transparent and talk about, we had a discussion around the stipends for the members for this group and how many, and use different departments. We were pushing and pulling and squeezing around compensation and what it could look like and what it comes from. And I just want to say it, and that's hard work because there's not a pool there for us to find. We have to find the resources and create these new pipelines. So that got a little bit messy.
Thanks for that call out, Vicki. I think that is so true. I think if we want those with lived experiences to be at the table and to contribute and to lead, we have to find ways to honor their time. I think it's super important, but it is really, really messy. But I appreciate you pushing on that. Darcel, anything to add?
Yeah, absolutely. So I think the biggest opportunity for improvement is true diversity in the representation of the advisors. And so that is always going to be a challenge. I think we are no different than Kanisha and Vicki shared with making sure that we have our men at the table. The other thing is our youth at the table. You know, we a lot of our PFAs, although they are open to both patient and family members, they typically are parent and caregivers, and we often don't have the patients themselves and our young adults at the table. And so I think where the opportunities land is really identifying where there are the gaps in representation. And so what we've started to do is try to do a diversity forum for all our advisors that really specifies racial, ethnic backgrounds, languages spoken, the areas when the hospitals are seen, their age or their children's age, gender, really to identify where there are opportunities, even down to zip codes, right? And just to really learn where our advisors, who they are, is going to be our first step in identifying where we need to target our interventions. And then I think more importantly is then meeting them where they are. I think recognizing that the model that we've typically used with in-person meetings, we know through COVID that doesn't work anymore and it doesn't have to work. But also recognizing that our families operate their patients, their families, they work, they're in school. We can't do everything within business hours. And so we're going to have to really be flexible and innovative and creative, one on when we hold meetings, when we hold the projects and the committees that we are asking them to sit on, compensation. They're experts in what they're bringing to us. We need to compensate. I know, Vicki, you spoke, and I am also an advocate of that and finding ways to do that. But I think the other opportunity is we will only get those people at the table if they feel their voices are going to be heard, which means we have to establish trust. And I think trust, specifically in healthcare, is there's not always a lot of trust, and then trust in the organization. So part of our work really is we're doing a trustworthiness campaign where we're reaching out to our advisors on our various councils in our community to learn their trust in healthcare, their trust in us, their trust with technology, their trust with all of the above, for us to really think about where we have to do the work to get them to the table. So to understand what are those barriers so we can meet them. And then to follow up with that is that once we get them on the table, we need to keep them at the table. And part of that is if they feel that it's just lip service and we're not doing anything with their voice, we're going to lose them. And so really being intentional about how we're going to close the loop, how we're going to share the work that we're doing and the positive impact that their voices had in order to them to fully see that we want, it's crucial, and that this is a partnership. And that will also help us to continue to foster these trusting relationships.
Thanks so much, Darcel. We can't do anything without trust. And we know that trust between our community, which when I say that means patients, families, and other partners, we have to recognize it has been eroded over time. And so we have to do the work. Kanisha, I know that, the work that you all have done as a PFAC really has, been trailblazing, but I didn't know if you had thoughts on what's your next step in this area.
Sure. So Vicki and Darcel hit it on the head, and we want to do more of that, more representation, not just cognitively, but do we have the right people around the table? Are we looking internally to reflect before we're looking externally? I think it's very important. And the retention of the people that represent those traditionally marginalized groups, and really we need to hear their voices heard. How are we creating a space that is helping them set up for success? and what that looks like. So everything that you said, I agree with. The other angle of it that I'm looking at is where we are having impact. For example, we've called our program the Extra Mile program, which addresses health inequity, and we're doing well. How can we accelerate that? How can we expand our reach? So again, it comes through partnership. Partnership with the hospital, for example, we're looking to partner with the Dalio Center and expanding this reach beyond just pediatrics. What other departments can we do it? And the acceleration across our locations at NYP will be significant. When we're looking to engage, I think engagement is really key within your council as well. So do people feel like they're making a difference? Are they given the opportunities to be able to step up to the plate? And are we really creating an environment of success to really foster that? And are we being open to thinking about things we never really knew from hearing those, ideas being put to the table and brainstorming on it? Are we really truly being open to it? So again, we need to show up internally before we can have that impact externally.
Thank you so much, Kenesha. I have one final question for the panel, and then I would love for us to address not all, but at least some of the questions in the chat. My final question is, what advice would you have for participants, listening in today on doing this work? How can they, be a champion within their organization as it relates to really trying to bolster PFAC diversity and getting PFAs involved in DEI initiatives? And Darcel, if it's okay, I would love to start with you.
Yeah, so the first thing is do it. It is important work, and I know it can be scary work, but it's essential work. So the first thing I would say, we have to do it. But I think, Vicki shared upon this. It's a multi-stakeholder approach, right? Is really find your partners. And I think I've seen a little bit of this in the chat is how do we reach outward to our community? And my approach is our patients and families are our community as well. And so really forging a partnership with our community affairs department. My co-chair on our patient and family community DEI work is our director of community affairs. And so we're really making sure that we are capturing the voices of not just the patients and families we serve when we're thinking about trust, when we're thinking about voices at the table with DEI work and social determinants of health, because this impacts those who we see and those who we don't see. And so really partnering with that group to make sure that we are doing this together. And then I think the other important thing is, it is okay to not know. It is none of us are experts in this work. And understanding that this is an opportunity for us to work together, to collaboratively, and more importantly, to do the work meaningfully and intentionally. So, just like the title of this seminar, that it's not just a checkbox, that we're going to do it and then recognizing it is not all going to happen all overnight, but if we work together and we're intentional, we will eventually see success.
Thank you so much, Darcel. Vicki?
Sure. I would say I've learned quite a few things in the past couple of months, and I would say one thing is you have to be really self-reflective in this work. Figure out, where you're operating from in the work and build your track. I love to speak in metaphors, by the way, you can tell. So like in building my track, I'm going to give you these are my 6 C's. So I have 6 C's that I'm really operating by. And those are comfort, convenience, and connection are the 3 of them. And those go together, which is trying to think about safety and support for our advisors as we think about diversifying. And I also think that I heard that, I can't take credit for those 3 words. There was some great group in Texas that was doing that work, and I loved it because they talked about convenience. We have to make it convenient for people to be able to be a part of our systems that have historically harmed them. So but then I added 3 more. So these are mine, other that I added, which are co-design. I believe that moves us from being transactional to transformational. I use that word a lot now when people are like asking for partnerships. I'm like, well, how can they co-design with you? And then, of course, this one, collaboration, cross-pollination. And the last one, I know you know this, is going to be, of course, compensation, which is we have to honor and amplify. If we're going to honor and amplify, we need to compensate.
Yes to all of that, Vicki. Thank you so much. And finally, Kanisha.
Yeah, so all of that good stuff. And I would say, it doesn't matter where you are along the spectrum, right? It's fine to start small. It's where you're trending. So I always say to everyone, if this is you're now starting and it could be intimidating, that's okay. Start small. Don't be afraid to fail. Keep yourself adaptable and be able to pivot. Celebrate every win. We talk about compensation and we know that's a more strategic, longer journey, but recognition is so key. Turning around and saying to someone, that was amazing, giving that feedback, self-reflection, thinking, what did we do well that we should continue? What should we start doing? And maybe what we should stop doing, and do that frequently. You're continuously improving. You're really boosting morale. And, all of these things together harness the collective coming together and doing it. And the final thing I'll say is burnout is real. You can get despondent. You can sit down and think, am I making a difference? But what we need to think is that this situation that we're in, all the systemic reasons we are in this situation has been for decades and decades. And the change is not going to just happen overnight. So give yourself some grace. At the same time, look for those small wins, look for those moments of joy that you can really push something forward. And collectively is always going to be better than the individual.
Amazing. I feel incredibly honored to have been the facilitator of this panel and to have learned from all of you today. So thank you so much for sharing your wisdom, your insights, and your experiences. And now I would love to open it up to answer a few questions from the chat. Pam, if it's okay, if I call on you to potentially find a few questions that we can ask, since you've been monitoring the chat for the past 40 or so minutes.
Absolutely. We have had a really lively chat with lots of questions. It's been fantastic. I want to just mention that if we do not have a chance to get to all these questions during our Q&A session, we will absolutely find a way to get answers to them for all of you. So there was a group of questions that related a little bit to recruitment. So I thought maybe we could start with a couple of those. Emily Newberry asked, as someone who works on the front line of patient partner recruitment, I find that one of the biggest challenges is the capacity of frontline staff who know the patients to keep in mind helping to diversify the pool by proposing specific people. So wondered if the panelists have anything to share about that. I will let the panelists jump in based on your experiences.
Well, I will share. I think absolutely our frontline staff for us is an incredible resource. They really get to know our patients and families. They hear our patients' families' experience in real time. And so I think for me, some of the work has been really sharing with our staff that we have not just one council, that we have more than one council, because right now, especially, with a lot of changes in dynamics and landscape and people don't know if they still exist, because we had to change how we were structured and how we operated through the pandemic. So really making sure that our staff know how they exist, the different ways that families can be involved, because we do have different tiers of involvement based off of a family's capacity and availability, whether that's not in person, but having to go through the whole special category, volunteer process with background checks. We have a virtual council. We have those that don't need that level of commitment. So making sure our staff knows the variety of ways, but also really closing the loop on kind of with our annual report for staff knowing how the family's voice has been used. I think that's equally important for our staff, not just for our families. So as they are speaking to families and they're asked questions, that they do have at the tip of their fingers either the information or know who to go to provide that to their families.
I would love to add a couple of thoughts to this. As a frontline provider, I think this is such an important question. And I wonder oftentimes if we leverage staff like our care managers and community health workers who have longitudinal relationships with our patients and families and know so much about them, if we actually can utilize them better and have them introduce opportunities for our families to get more involved in our institutions. I also think there's probably a way to provide information to families on a regular basis. You know, our families, when they're coming into ambulatory clinics, you know, they have to, you know, fill out a lot of different things. You know, what if, like, you know, on an annual basis or a semi-annual basis, you know, we ask a question about, are you interested in getting involved, you know, with, you know, institutional efforts? We have several ways in which you can do this. If you want, happy to provide more information. So I think we have to be more proactive. I don't know that we do that in a consistent way, and that we provide that level of transparency to every patient and family. And I think it would be really cool if we found a way to do that.
And just in we all think about recruitment all the time, I think, right? I sleep and think about recruitment. Really quickly, we're creating a tool. So what I realized coming in, and what we realized, is we have a one-pager that has too many words. Our rec cards, too many words. It's English based. And so we realized some of our staff aren't totally able to articulate what an advisor is. So right now we've been co-designing with a graphic designer and with our advisors of an infographic. I mean, it seems really simple, but we needed a good infographic that we can show people. Here's what it looks like to be an advisor. That was really, really simple in plain language. And we're excited. When we roll that out, that's going to everybody. First, to the providers, to staff, to advisors, to community partners. We're going to really blast that out.
And I'll just quickly add, you know, we found through our data that we have the most success through referrals. And so we develop and build that partnership ongoing. So to the point that on the front lines, all of the staff are constantly thinking about us. So when a family comes in, they're already thinking, maybe, is this family going to be a good referral, etc. And then what we do is we take the next step to look at our data and see where we have the gaps in cognitive diversity, and we go to our partners. So for example, we had a gap in oncology, went to our partners, got the referrals, and then had a super successful implementation in our emergency room based on that start point. So immediately we can see how that line works. And I think it's really key, again, to take that data, but to also focus on the people aspect. How are you communicating, how are you partnering, and how are you making sure that you're showcased every day by people who really have their finger on the pulse?
That's great. Thank you all. There's another set of questions that is related to developing and fostering inclusive and safe spaces, and wondering if all of you can talk a little bit about that. So I'll read a couple of questions to sort of give you an idea of what people are asking about. So Jessica Tang noted that Kanisha talked about developing psychological safety when engaging with advisors from diverse backgrounds, and wondering what that might look in practice. Aiden Scott asked about fostering safe spaces, and that includes creating that safe space with staff at internal DEI tables who feel like they can't be vulnerable. And Rosie Bartel asked about hearing stories and using messages that people bring without judgment, which is obviously part of creating a safe space. So just wondering if all of you can talk a little bit about that process of fostering safe spaces.
Sure, happy. Oh no, Vicky, please go.
I was just going to say, I think part of it is having people who, when they come to that space, there are other people that look, sound like them is right there. There's a connection. I'll be on, like, so for me, being bilingual and speaking Spanish is hugely, right? So sometimes people might look at me, they don't know Spanish until they say that little tilde in my name, and then they're probably like, oh, she probably speaks Spanish, you know? But it's like, it opens the gateway, and it's a way to partner with people. And I think that we have to cultivate staff and other people at the table, other advisors, so that, like, from a basic place of affinity, that people can find, you know, connections that way.
I think Vicky and I totally connected, because that's exactly what I was going to say. It's so important to see it to be it. And so taking a direct example, as a woman of color that's a working parent, I know that another person who looks like me will feel more comfortable speaking to me to say, what is the real world situation of being able to give my time while I work and look after children, and how do you do it, and what does it look like in reality? The other part of it, of creating a psychologically safe space, is meeting people where they are. So, you know, to get those voices heard, you need to understand the dynamics of the personalities and how you can help that person have their voice heard. Some people have a sense of autonomy and can hit the ground running. Others will want you to be there supporting and be that support in the background. There are many different ways to do it. And the key about it is to be adaptable, to always think about it, to take that feedback, and to just be really transparent about your efforts. Are you retaining it? Are you getting the outcome that you want? And I know one of the questions was, how do you go about doing that? And we use surveys, for example, to gauge our engagement and where people are thinking. And so we try to use that in setting our priorities and figuring out how we should, as a council, be more effective.
I think what I'll add is that part of meeting our families where they are is sometimes learning that we have to create a new space. So, and I think Kenesha spoke a little bit about this, is, for instance, when we were trying to recruit Spanish-speaking families to our system-wide advisory council, where the meetings are held in English, right? And even when we tried to bring in an interpreter for that, they just weren't connecting and they weren't contributing in the same way. And so recognizing that approach was not going to work, and we needed to create a whole brand new space, such as a Spanish-speaking council, where they can speak and hold all the meetings in Spanish, right? And that was something that we were going to have to do to create a safe space where they felt that they could freely share their experiences, but also be more connected to it and more connected to the work. And we're having to do that same thing with our youth and with our teens, and creating a separate teen leadership council, recognizing that our teens are saying, you know, they don't necessarily feel as safe and confident and having these conversations with other adults. And so really creating an environment that's built around that group. And we've followed that model in some other areas where, you know, when we think about the conversation of social determinants of health, so a lot of our community work is really about specific areas and the district and in Maryland specifically, where you know, that is their issue. When we created a specific advisory council that is of those patients and families, and that has really, one, helped us create spaces for them where they feel they can share their experiences without judgment. And I think the other part that is often difficult, not just in DEI work, but in general, when we are talking about staff and having patients and families at the same space and same table of staff, is really making sure that we are creating a groundwork of teaching and training our staff what that looks like to have parents at the table, and for our patients and families, what it's like to sit at a table that has diverse stakeholder members, what they also feel that their voice is equally important. And that is going to be ongoing work, is right, really training families how to be advisors, but training our staff on how to have advisors on their team. And that, I think, you know, is beyond just DEI. That's just work that we will continually have to do.
Another question that was asked related to the type of EDI training that is provided for family advisors to help foster a welcoming space. Do any of you provide that type of training to advisors? Darcel, would you mind talking a little bit about that?
Yeah, so thank you. So part of our there is an onboarding process and an onboarding guide that is given to all of our advisors, and we do have different tiers, so that does look different depending on, you know, the extent of the work that the advisor is going to do. But really, one that really teaches them what an advisor is, the difference between an advisory council and a support group, which I think, you know, in this conversation, I think all of you can identify with. Sometimes people don't understand the differences of that. Understanding how the work that the council is doing is going to be bilateral. It's going to be things that the organization is going to come to the council for wanting your input, but also to bring things to the table too that we want to kind of escalate. But how to meaningfully tell your story in a way that can be heard as part of that orientation. But then part of what we're building, and I say building because it's ongoing, is this is not just our advisors, this is also our staff. It's really connecting with who are leaders on the staff are on a project or committee and saying, this is the advisor who's going to sit in your council, providing them a little bit of background of that advisor, so that they can also make an introduction, right? When that advisor first joins the work, especially if it's been a pre-existing, body of work, they can make that introduction and make the advisor feel welcome. But then I work to check in with both. Check in with the advisor, check in with the staff lead to say, how is that dynamic working, to make sure that that they continue to have a really well-developed relationship and that both feel like it's a partnership.
Thank you, Darcel. I want to ask the group another question that, or a set of questions that relates to kind of how you consider diversity. So Aidan Scott mentioned that sometimes a single table will never be big enough for adequate representation to sort of completely reflect the full diversity of patients and families served. And Rosie Bartel also mentioned that there are diversities that at times aren't visible, like some disabilities. So can you talk a little bit about how your organizations are considering and thinking about diversity when it comes to advisors, and then kind of making sure, like, how are you thinking about the diversity that needs to be represented within your advisory council and your advisors? I will, yeah, Vicky, please go ahead.
I was just gonna say, like, two really quick things that are coming off my head is data. I mean, there's the data. We need to look at who our patients are, who are the communities we serve. I think that's a continued work in progress. I haven't found the perfect data set or the perfect report to run, so it feels like it's in my department and other departments. So looking at data. The other piece is just, we've been talking about this, it's partnerships with the communities we serve. I feel fortunate because my director, when I came on, I said, I need community partnerships, I need them. And I felt like she also gave me a financial backing so that I could do things with our community partners around that. And whoever just talked about invisible disabilities, or that struck a nerve because that's what my daughter, so it's chronic illness, invisible disability. I think that I think about that a lot, but that's from my own place of my personal experience. So I think part of it is continuing to cultivate stories. Probably didn't talk enough about stories, is if we are hearing about from our patient stories and finding pipelines so that the stories are getting to the right places, I think that we'll also be able to make more spaces for the stories and for the identities behind those stories moving forward.
How about others? Kanisha?
No, I agree. We look at our data, we look at the communities that we serve and where the gaps are, and we want to represent that. Additionally, clinically, we look across the board. We may be heavy on NICU, so we acknowledge that and think, where are the gaps? We need more experience, to your point, Vicky, about chronic illnesses. How do we go about getting those families in and creating a space for them to be able to have impact? So we look at it from multiple dimensions. One of the things that we also just try to do is have our council be more reflective of the communities that we serve. And, while it's easy in theory, it's a bit more difficult in practice. We're constantly looking at ways, because that kind of gets you halfway there, right? When you have that representation, and then you can empower and engage those people to be able to help. And I think also making sure that we don't just have tokenism, and really understanding how we are addressing the key issue and holding ourselves accountable through looking at our measurable impact and being able to pivot until we get to the goal that we're looking for.
And I don't think I'll add to that. I spoke a little bit about it, is we actually have created a demographic form. And I know really that is going to help us and our team kind of take a look at who our population is and where there are gaps. And I've seen something in the chat, like, how does that come across that you ask about it? But I'm honest about it, is we want to make sure that we are representing the diversity of the patients and families we serve. And this helps us assess kind of where there's opportunities. And families do not have a problem with that and with completing it. And like I said, it's everything from not just, language spoken, religion, but just even on the demographic form is kind of asking them, what is your skill set, right? What are your strengths? Because I think really when I'm thinking about how I'm going to recruit families to the table, it's not just about looking at their race or their language. It's where they want to do the work at. Like, what are you passionate about? So I can really try to identify the advisor and match them to the work that they want to do. And so I look at the demographic form really as an opportunity for me to learn about the advisor so I can best pair them to the work that they want to do.
It's such a good, I was just going to say, such a great point. One of the things we do is annually we ask our members of our FAC, what would you like to do and what skills do you have? So, some of our members are fantastic at marketing and really good at putting those gift bags together for the event. And we have such a huge impact. And they're doing something that they love, that they're good at, that on the surface we might have thought, oh, we brought a bilingual member in, but actually this person's amazing at running events. So I would say it's, not just incoming, but ongoing every year. And, if you give people the opportunity to do something that they love, then it's already, cultivating that sense of inclusion and really having the impact we're looking for.
I just want to amplify what both Darcel and Kenesha mentioned. I think Kenesha mentioned the risk of tokenism. And I think if you are thoughtful in really trying to identify the skill sets and the strengths that PFAs are bringing to the tables, that is the way in which you build a sense of belonging and inclusivity. I also think it's important to recognize intersectionality, right? We are not one-dimensional in the people that we are, right? And so people can, have multiple social identities that is relevant to this conversation. And so just really keeping that in mind, I think, is important. And, really let the data drive the work and let the priorities drive the work. People don't want to feel like they're sitting at the table when the organization is not really focused on addressing a particular area that they're really passionate about. I think that just does a disservice to everyone and is not really honoring of that person's time, experience, or skill sets.
Thank you, all of you. I will add that we heard in the patient and family advisor focus groups that we did, kind of building on the notion of tokenism and identifying what it is that advisors want to do, that some of the advisors said, were brought in. And it's very clear that we've been brought in to increase diversity. And then anytime there's a question that relates to DEI, it's immediately targeted and, geared towards us. And that's not, all that I am, is what they were saying to us. And I'm not just brought in to do the DEI work. I want to, be a complete advisor. I want the ability to contribute in the ways that I feel like I can support and really strengthen the work. So I just want to amplify the notion of really getting to know advisors and what it is that they're interested in and what they're bringing to the table. I think we have time for one last question before closing. I know there are some things that we haven't gotten to. I promise I will go through the list of questions and make sure that we can get you responses to all of them. I wanted to raise one question that Brandon Smith put in the chat. He noted that they are challenged by inclusive and equitable practices. So, for example, patient and family advisors are technically volunteers in our system and currently required to undergo criminal background checks. Do you have experience with redefining patient and family advisor roles and requirements to create more inclusive councils, and any recommendations on tackling this within a large health system? Darcel, I see you nodding. Do you want to take that?
I think that's really important. I put a little bit in the chat, but it was hard to probably not type it clearly. But that is a barrier to some of our families. And so really to be more inclusive and meeting families where we are, is we develop different tiers. And so understanding that some of our advisors, depending on the nature of the work they're going to do, we're going to need that, right? We're going to need the background check. We need the medical compliancy. And some of the work our PFAs do, that requires that we are now determining that our family is faculty. These are families who have completed that process, have a background check, drug testing, medical compliancy. They can come in, they can do lead focus groups, town halls with our patients and families. They can round on patient and family centered rounding. They can speak at new hire, do nurse simulation training because they have had that. But recognizing to meet our other families, we can't have that as a barrier. And so that was why we created the different tiers. And so our PFAs, our patient and family advisors, they don't need that. We're just asking them to commit to a committee or project. And now that we know we can operate in a virtual world, that works perfectly because everyone does not need to come in for meetings. We can do them virtually. We can round virtually. We have telemedicine now. And so really recognizing that some work needs in-person, needs that, but others don't. But more importantly are, really expanding our virtual council for those who may not be able to make the commitment, but that still want to have their voices heard and they want to participate as they can and as they want, depending on projects and tiers, has really helped us diversify. And I think really an interesting thought for us, we have actually had more family members wanting to serve advisors through the last couple of years in pandemic. I think it's really changed what's valuable, what's important, and people where they want to utilize their time and their voice. And so instead of this new virtual world where you would think it would decrease membership, it has actually increased membership for us and allowed us to diversify our advisors.
I just want to amplify what Darcel said around a tiered approach. I think that's really creative. I think we need to get creative and keep thinking around the tiered approach for advisor work. And I did want to say, I saw in the chat that someone had said for their background checks that if someone does have a misdemeanor or something like that, there's something that comes up that doesn't exclude them. Conversations still need to happen around this. And I just want to share that as we're creating our community council, we had a really specific conversation about what onboarding would look like for our community council members, and does it look the same as the other patient family advisory council members? And right now we're talking about to keep it the same, to empower that group to be at the same perceived level as the other ones, because we didn't want it to be perceived as lesser in any other way. But I just want to say, I do think, considering moving forward barriers, we always have to have this conversation moving forward in 2024, 23, 25, 26, 27, 28.
And the one thing I will add to that, I agree with both what Vicky and Darcel have said. We talked about thinking outside of the box, right? So what do we want? We want to be able to get that feedback and act upon it. So we don't necessarily have to create a barrier of having this a person or family as a family advisor, but we can use real-time feedback, focus groups with families to get that feedback and be diligent about how we're going to apply it and incorporate it into what we do. And that's one thing that we have done at New York Presbyterian that's been quite significant. One case in point is the accessibility of affordable food when you're in the hospital and you live too far away. And we were very quickly able to offer free food and lunch during the weekdays to families with good feedback, as well as thinking about the diverse community that we serve, offering vouchers for halal and kosher meals, etc., that may not have been available on the free lunches, so that we were including everyone. And that would be one example where we were able to partner with our families in a different way, get that feedback and still implement on a council level without having to go through extensive, barriers to getting those families on the council.
Thank you so much to all of you on the panel. This has been so incredibly valuable, and I appreciate learning from all of you as we continue in this work together. So thank you, Ndidi, for moderating, to Darcel, Vicky, and Kanisha for all of your thoughts. Just a couple last slides. Next slide, please. So I want to leave you with a few thoughts. And while there are words on this screen, I actually want to leave you with amplifying a few thoughts from our panelists. So Kanisha said, it's fine to start small, but celebrate what you are doing well, learn about those successes, build on successes to continually improve so that you're moving forward. Vicky talked about being self-reflective and building your track forward with intention. And Darcel said, do it. It's important work. It can be scary work, but it is essential work. And I think those are the words that I'd like to leave everybody with. The other thing that I would like to mention, next slide, is that we are a community of people. So we are all in this work together. We can all learn from each other, and we hope that there will be ways for us to continue doing that. IPFCC has frequent informal conversations that present an opportunity for our community to come together and to learn from each other. They're not formal webinars or presentations like this, but they do have the same type of interaction with people learning with, sharing with each other. So I want to just amplify those. Finally, we would love for you to fill out the survey. We will also send this around afterwards. But this just gives us some feedback about the webinar that we can use to continually make sure that we are providing the information that will benefit our community. So thank you to all of you for being on the webinar today. We're extremely grateful for your time, and we look forward to learning about what you will be doing in the future as a result of what you have learned in this webinar. Thank you, everyone. Enjoy your afternoon.